So currently for cardiac investigations, they use adenosine due to its vasodilating effects. And when given as an infusion for these investigations, there's about like 20% of the patients that report having a headache. And if you then go into other substances that you can also use that increase the amount of adenosine in the human body, such as the substance called dipyridamole, there's also clinical studies that show that like if you give dipyridamole as an infusion to healthy volunteers, they experience a headache, whereas migraine patients report migraine attacks in 50%. And then there is like an old clinical study as well that showed that if you gave it on a daily basis to patients with migraine, they had an exacerbation of the headache intensity in general. So that's like one part of the clinical data that we have currently on adenosine in headache and migraine. And when you talk about adenosine, you cannot not talk about caffeine as another thing. So caffeine is a substance that goes in and blocks these adenosine receptors and how adenosine works. And if you look into like caffeine itself, again, it's a lot of I think it's about about 20% of migraine patients actually report that caffeine can trigger their headaches or their migraine attacks. But at the same time, there is also a lot of the migraine patients who report that taking medications that has any kind of simple energetics in combination with caffeine actually treat their migraine attacks. So there's the ability of caffeine to both trigger the migraine attacks, but at the same time, it can also works as a treatment. And you would wonder, why does it have dual effect? How can it work in both aspects? And to better understand that, I would mean that we'd have to look into the receptors itself, so the adenosine receptors. And currently there's, as far as we know, there's 4 different receptors. And 2 of these receptors, the A1 and A3 receptors, are known to be antinociceptive, and also it can be vasoconstricting. Whereas the other 2 receptors, which are the A2A receptor and the A2B receptors, has the opposite effects. So it goes as pro-nociceptive, causing pain, but it also has a vasodilating effect, which is also the opposite of the other 2 receptors. And in this case, it would be interesting to look into the preclinical studies that is based on the receptors, because most of them look into the receptors rather than just adenosine itself. So in preclinical studies, that involves the trigeminal vascular system, which is believed to be like a substrate of headache and migraine pain, both anatomically and physiologically. It seems that if you do electrical stimulation of the trigeminal ganglion, the expression of the A1 receptor, so the antinociceptive receptor, it decreases, whereas the A2A receptors, which is the pro-nociceptive, so causing pain, those receptors increase in the opposite, goes opposite again. So this would suggest that pain itself, somehow is regulated by the amount of receptors that we have in our brain. And there is also preclinical studies showing that if you give if you activate the A1 receptor, then you can actually inhibit the firing of the trigeminal vascular system. So one, you inhibit the pain translation that's happening, and secondly, there is also studies showing that by activating the same receptor, that CGRP, which is also known to be involved in migraine, the release of CGRP decreases. So activating the A1 receptor somehow seems to be a treating effect, or it helps on it decreases the pain transmission and decreases possibly the involvement of a migraine attacks. Whereas if you look into the A2A receptor, which is thought to have maybe this vasodilating effect and pro-nociceptive effect, we see that if you activate that one, you cause vasodilation, which we also think is involved in migraine, and the effect of this vasodilating effect can actually be blocked by caffeine. So again, caffeine comes into the picture, and it seems that the effect of maybe the treating effect of caffeine could be its blocking effect on the A2A receptors. But currently, we don't have that much information rather than the things I just mentioned in regard to adenosine and the receptors in both headache and migraine. So I would based on our review, we suggested that focus should be on specifically the A1 receptor, activating the A1 receptors, and otherwise it would be to inhibit or block the A2A receptors, which is usually the one that causes pain, it seems. But again, it's limited, and it seems to be complex, more complex than we just assumed to begin with.